So let's get started in our last presentation today. Last speaker is Dr. Bruce Korf. Dr. Korf is originally from, or went to school at Cornell, interestingly, in New York, in Ithaca, New York, and undergraduate degree was in biology and genetics, and then went to Rockefeller for the next 5 years to get his PhD in genetics and cell biology. After that, he went to Cornell in New York, in the city, for his MD degree in 1980, finished in 1980, and then began residency, fellowship, and residency. So his first residency was in Boston at Boston Children's in pediatrics, did a fellowship for 3 years in genetics, also in Boston, and then continued in Boston in a neurology training program, finishing in 1985. So he stuck around the Boston area, was associated with Harvard Medical School, the pediatrics, was a pediatric instructor and medical instructor there until 2003 when he moved down to Alabama. Since 2003, he has been associated with the University of Alabama, Birmingham. He's chief of the Department of Genetics there, boarded in multiple boards, including medical genetics, psychiatry, neurology, and pediatrics. Please welcome Dr. Korf.
Well, thank you very much. It's a great pleasure to have an opportunity to participate this afternoon. I actually do feel the weight of the challenge on my shoulders, which is to make anything interesting at 4 o'clock on a Friday afternoon after you've been sitting here, as I understand it, for 3 days listening to talks. So do the best I can to try to make this interesting and relevant, and that is not a given, I realize, when we talk about genetics, because a lot is changing, but historically genetics always did sort of get put to the back of the book. Not a lot to disclose here. And if I were to tell you that this is really the engine that's driving a lot of medical practice, it might seem counterintuitive. You're looking at a small chunk of the DNA sequence, 2,000 bases to be exact. It is not the most interesting reading, I will agree, looking at it in this way. But what I'll try to convince you is that this is moving us from a descriptive sense of human physiology and pathogenesis of disease into a perception really of the cell and the genome almost as a living, breathing entity unto itself. It turns out it's not just the base sequence and changes of base sequence that matter. In a certain sense, you can say it's the font of the base sequence even that changes. Sometimes the same base will be there, but with slight chemical modification. It even matters where things are physically in the nucleus. What sits next door to what makes a difference in terms of the way genes are expressed. And where it's leading us is towards an ability in a way to kind of reconstruct the physiology of the organism, to describe the networks of interactions between the various players, and then to use that to inform our approaches to treatment. Most people, when they think of genetics, think of the very far left of this slide, the so-called monogenic traits like sickle cell anemia, cystic fibrosis, and Huntington disease. And a lot has been learned about the pathogenesis, management, and even, in some cases, treatment of these disorders. But what you'll see is that we're now turning attention towards common disorders, things like asthma, hypertension, and diabetes, that are not solely determined by genes, but instead where genes, very much as the last speaker was alluding to, by the way, contribute towards risk. But it's not just one gene acting in isolation. It's genes acting together and in concert with the environment. And the tools finally are at hand to understand what those genes are that contribute to common disease. And the question will be, how we'll be able to use that to provide better care. Pharmacogenetics and pharmacogenomics has become a huge area, both in industry and one that is increasingly going to impact on day-to-day practice. And finally, cancer is fundamentally a genetic disease. It's always due to changes at the genetic level, sometimes inherited, and you'll see an example of that later, but at least at the somatic level, always the consequence of an accumulation of genetic changes. And so the question is, if those can be characterized, can we devise better ways of treating? Now, while all of this happens, our patients are acutely aware that something very interesting is going on. And it is not rare for patients to come into the office having a clipping from a newspaper or something pulled off the internet, and the question will be, is this going to make a difference in the way you treat my condition? And certainly public expectation has been set at quite a high level. We'll say more about it later, but it's been very much in the news actually just this week. You may be aware that if you're interested in genotyping 1 million single nucleotide polymorphisms from anybody, yourself, anybody else, you can log on to a website and do that. Here are screenshots from 3 of the major companies that offer this direct-to-consumer testing. And really the question from the physician's perspective is, what do you do when somebody puts a printout on your desk, as they now are quite capable of doing, and says, so now what, given the various risks that have been ascertained through this approach? And just this week, as you know, probably, Walgreens announced and then quickly retreated from a plan to market direct-to-consumer genetic testing in their stores. And it was actually intervention from the FDA inquiring whether they were actually putting forward a diagnostic approach that had not gone through FDA approval that caused them to back off. We'll say more about this direct-to-consumer genomic testing, but this is not a someday this will happen. This is happening and has been for about the last year and a half, and we'll talk later about where it's all going. So I thought one way to approach this is to ask the question, how will a healthcare provider use genetics and genomics, and when will they use it? And one way to look at it is to stratify the world into these 3 layers: prevention of disease, diagnosis, and treatment. And to ask, what is it possible to do today? What could you go back to your office and do Monday? What might you even have done in this last week? And where are things going in about a 5-year time frame? If you're talking to medical students or residents, what you're really saying is by the time you graduate, whether it's from medical school or residency, but it applies at any stage of career, where do we think things are going? As I alluded to earlier, you need to realize that there is a kind of 2 sides to genetics as it relates to medicine. And do remember that the rare disorders that has been the kind of bedrock of genetics practice historically are not going away, and there are enormous opportunities now to provide better approaches to diagnosis and treatment. I'll show you a few examples of that. But meanwhile, if the assumption was, well, that's fine and important for those people who need to deal with it, but it isn't going to make a big difference in my day-to-day practice, those days are quickly changing. And I think there will be a point over the career lifetime of probably most in this room where most medical decisions have somewhere behind them, a few layers back, some kind of genetic test that helped to inform how that decision was made. So where are we in terms of prevention? Let me just give you a hypothetical family history. This is an individual, the one at the far right with the arrow, who has requested some information about hemochromatosis. And the reason why is that his brother, the male at the far left shown in red, was just diagnosed with hemochromatosis, and he's now come to realize that this is a condition that can run in families, and so this has never been an issue as far as he knows or you know before, but now the question is what can be done to approach this. I'm sure you're aware hemochromatosis is a disorder of promiscuous iron absorption. The iron deposits in tissues where it's toxic, cirrhosis particularly, but also diabetes, heart failure, and a variety of other manifestations. And it's fairly easy to treat if diagnosed early, that treatment being phlebotomy, which is a way of removing iron. Hemochromatosis is an autosomal recessive trait, so that means both parents of an affected person will be carriers and face a 1 in 4 chance of transmission to the next generation. And the major gene that is responsible, which goes by the terms HFE, has 2 mutations that are the most common, one of which accounts for the vast majority of instances of hemochromatosis, and heterozygosity between that one and another for most of the other cases. So the genetic testing is not so awfully complicated. Now, does that mean that we should be doing genetic testing on a wide scale? By the way, the frequency of a hemochromatosis mutation in individuals of Northern European ancestry is about 1 in 10. 1 in 10. So calculate that means 1 in 400 people of that ancestry will be homozygous, but not 1 in 400 people, you probably know, are afflicted with hemochromatosis clinically. And the reason is that there are probably environmental, maybe other genetic factors yet to be discovered that seem to interact with this gene, and so it is not completely deterministic. So the argument would not be that everybody should be screened for a hemochromatosis mutation, even if they come from an at-risk population. The argument is to think about family history and to ask the question whether there's a family history, particularly in an individual of an at-risk ancestry. And the study that I've had on the screen for the last couple of minutes was published a few years back, actually almost 10 years back now, in the New England Journal. And the question they asked was, take people who have been clinically diagnosed, find out their gene mutations, or really find out if they have this common mutation, and then offer testing to their siblings who at the time when they were tested were not known to be affected, but now based on this family member are at 1 in 4 risk. So of 113 men and 101 women of what were previously thought to be healthy individuals, SIBs of an affected person, 14 already had cirrhosis and didn't know it. 13 had liver fibrosis. 11 had transaminase elevations. These are among the men. There were 3 with diabetes, 10 with arrhythmia. Fewer women were affected, and that's because of chronic blood loss due to menstruation and pregnancy is essentially a kind of self-treatment, and so the penetrance, the likelihood of having symptoms in females, is lower. The point here is not so much that everybody should be screened for hemochromatosis. It's that if there's a family history of it, it can be life-saving, actually, to recognize this and offer testing. And the testing, which actually is done first by a transferrin saturation, is very straightforward. And the treatment is very straightforward, but it only works if done prospectively. Here's another example of the power of family history. So this is actually a family that we're seeing in our genetics clinic. And the person who sought counseling is, I realize half of you looking at one screen and half the other, so it's this person off to the far right. And why she was concerned is that her sister in the same sibship has breast cancer. And then on the father's side, there's an individual, a male with prostate cancer, a aunt with ovarian cancer, and another aunt with breast cancer, and the paternal grandmother had breast cancer. So a lot of breast cancer. There's also significant cancer, by the way, on the other side of the family, lung cancer and leukemia. So her question to us was, is this enough family history to be concerned, and is there genetic testing available? Well, in fact, what we arranged was to have not her, but her sister tested. Her sister, because she, being affected with cancer, if there is a gene mutation in the family, we would expect that she would manifest it. And indeed she did. So she had a mutation in the BRCA1 gene, testing done a few miles down the road here, by the way. And on that basis, then, we can conclude that the family risk of breast and ovarian cancer is likely accounted for by this mutation, which conveys an 80+% risk of breast cancer. Now, breast cancer is not rare to begin with, but not that common, and also a substantial risk of ovarian cancer. It allowed us to offer testing to the woman who had originally sought counseling. Unfortunately for her, she was negative, which is a significant result. If we had tested her first and she were negative, we wouldn't know if it's because we couldn't detect the mutation in the family, or there was no mutation to be detected, or whether she was really negative for what conveyed the family risk. Whereas knowing that the sister was positive gives that much more meaning to the result in our patient. And this puts her risk back down to the population baseline and means that she does not need to be thinking in terms of interventions. Now, you may remember when the breast and ovarian cancer genes were discovered and testing began to be possible, that there was, which is in the mid-90s, there was a perception, well, it's a great advance, but is this really such a good idea? Why would you want to know the name of the thing that you have a good chance of dying from if you can't do anything about it, was the perception. And that was a fair criticism, I think, at the time, because the gene discovery obviously predated any effort to identify effective therapeutic strategies. But in the time that has passed, it is clear that there are effective interventions that can substantially modify the risk of breast cancer. This Kaplan-Meier curve shows the outcome of surveillance, which is the lower curve, or salpingo-oophorectomy, which is the upper curve. Farther down you go, of course, the more likely you were to have developed cancer. There's a substantial protective effect, not just for ovarian cancer, but for breast cancer as well, for having the ovaries removed at menopause. So this is an intervention. Mastectomy is an intervention that many women will choose faced with a very high risk of breast cancer. Chemoprevention now is possible. And surveillance, much increased and begun at a much younger age, is feasible too. So this is a far from academic thing, and we're seeing many people per day now in our genetics clinic, and I'm sure the same is true in this area as well, with a risk of breast, ovarian, and colon cancer. These people don't look any different than anybody else that comes into the office on any given day, unless they have cancer, of course. But the way you figure out who is at risk is by virtue of family history. Family history, I realize, is not it's an easy thing sort of to conceptualize and a hard thing to do really well, because time is obviously precious in a clinical encounter. And there have been a lot of individuals interested in creating ways to simplify the family history process. I'll draw to your attention the Surgeon General's tool, which is available on the web. It's a freely available sort of approach that really puts the sort of tools in the hands of the individual, not so much the physician, to take their own family history. Obviously, who knows the family history but the family? And they've tried to encourage the concept of using Thanksgiving as a time to sort of gather all this information when people are likely to be together, and then put it in a form where it can actually be shared with a physician, particularly for sort of actionable things like cancer risk. I wouldn't advocate that we make our decisions as to what to do based on legal precedents, but there are two that are just worth pointing out. The one on top is an individual diagnosed with medullary thyroid carcinoma 3 years after her mother is treated for the same. So she sues her physician, arguing that there was a duty to warn of the possibility of genetic transmission. Risk is dominant. The court found there was no duty to warn the children directly, but there was to explain to the patient the possibility of familial implications. And the second case is particularly chilling, I think. So this is somebody whose father is treated for colon cancer, turned out to be associated with familial adenomatous polyposis. 20 years pass. The physician who treats him is deceased, and then a relative develops colon cancer and sues the father's physician's estate. So if you thought that by dying you were beyond the reach of the malpractice world, think again. The family won that case, again, on the assumption that there was a duty to not so much find the children, who were probably too young to counsel at the time anyway, but to explain and document to the individual that there is a genetic risk. So these genetic risks are anything but academic. Well, where have we gone in diagnosis? You're probably familiar with the syndrome shown here, Down syndrome, and the picture to the right are the 47 chromosomes that are characteristic of that. It's a very old picture reflecting the way chromosomes looked in the early 1960s when this testing really began to be done on a wide scale. If you were to take a modern look at the genome, these are the same chromosomes, but what you're looking at, each of the blue graphs, shows the density of genes along the chromosome. This was published just after the human genome sequence was elucidated. It's an interesting thing to point out. There are what you might think of as gene cities and gene deserts. Genes are not evenly distributed along the genome. And if you think about which are the 3 trisomies that are compatible with live birth, 21 I just showed you, 18 and 13 are the other 2, and you look at 13 and 18, they're almost completely flat. It could have been predicted which would have been the chromosomes you could be born with and have a full extra copy just from looking at the gene density. All other chromosomes have so much genetic information that the imbalance of trisomy is lethal. Well, there are some major things going on in terms of the transition of care from childhood to adulthood for many disorders, Down syndrome particularly. Not too long ago, a few years ago now, we got a call from a group in the Birmingham area, parent advocates, Down syndrome, they call themselves. They were pretty happy with the care their children were getting. Pediatricians were pretty savvy about the kinds of needs that children with Down syndrome face. But as their children were growing up, which now they are, because between antibiotics, treatment of leukemia, and cardiac surgery, most of the early onset lethal complications can be managed, these families were very unhappy with the care their adult children with Down syndrome were getting because the internists in the community were not that sophisticated about their needs and were nowhere near as able to provide for them as pediatricians were. And sure enough, there was a significant increase in survival. It led us to set up an adult Down syndrome clinic that caters to the kind of primary care needs of individuals with conditions like this. This kind of thing has been happening in a variety of areas. Cystic fibrosis, another example of a disorder where the survival is gradually going up, not because of gene therapy, but just because of better conventional therapies. Congenital heart disease would be another example. The terrain in diagnostic testing is moving very quickly. This child has a fairly common condition called Velocardio syndrome. Velo for cleft palate, cardio for coronal-truncal heart malformations, facial because of some distinctive, but not that distinctive facial features, widely spaced eyes, narrow eye slits, for example. Associated with a deletion of chromosome 22, you can light up the critical region in red here, that's the normal 22, and the deleted one is off to the side, so it's the normal and the deleted one. This fluorescence in situ hybridization, it's been around about 15 years now, has made a huge difference. For years, these children were not being diagnosed. Once this technique was introduced, one by one, many of the children being seen in the cardiovascular surgery area turned out, in fact, to have this. Well, the front has continued to move. There's a new technology of genomic cytogenetics. In this one, array comparative genomic hybridization. You take sample from a patient, mix it with a control, and let them compete for DNA sequences on a microscope slide, basically, where you can represent the entire human genome on this slide. And you get pictures like this, where you can diagnose a deletion that was way below the level that would be visible with the light microscope. It's being used especially in individuals with developmental delay and autistic spectrum disorders, where the pickup rate of small deletions and duplications is hovering now around 20%, whereas before only a very few percent of them could be diagnosed at the genetic level. This was a screenshot from a paper showing a deletion in one area that has been found repeatedly in individuals with autistic spectrum disorder. But in fact, these rearrangements can be anywhere in the genome, and you don't have to know in advance where to look, because this is a technology that literally looks everywhere simultaneously. There has been an exponential increase in the ability to do genetic testing. And this screenshot comes from the website genetests.org, which is a publicly funded database of genetic testing. Gives you a sense of just how many genetic testing labs there are, both commercial and academic. And if ever you're in a situation where you wonder where in the world is a test done for a patient that has a problem that you're interested in offering testing, the genetests.org website would be a place to look. The testing terrain, though, is not a simple one. One needs to be thinking in terms of what are the indications. The pitfalls of interpretation can be complex, as can the counseling. My own area of research interest is a fairly rare condition, neurofibromatosis type 1. And this is a diagram of the NF gene. And I won't go into any further detail than to tell you it's about 300,000 base pairs from end to end. Every mark below or above is a different mutation in a different patient. And without saying any more than that, the complexity of interpreting this really can be quite substantial. What about treatment? Well, although many people formulate the kind of view that, well, genetics does not really deal with treatment, that most of the conditions we deal with can't be treated, that certainly has not been true historically, and it's more and more the case that we have possibilities of intervention. The first major interventions that were feasible for genetic disorders were along the inborn errors of metabolism. As you, I'm sure, know, at birth, every child has a heel stick, a little blood is drawn and blotted onto filter paper. It goes, in most places, to a state public health lab. Originally, the test was, as shown in the upper right panel of the four, a very low-tech test based on bacterial inhibition assays that was able to diagnose PKU and perhaps upwards of half a dozen other things. And the reason to do it was that if you waited for signs and symptoms of these inborn errors to show up, it was already too late. And that child already would have suffered irreversible brain damage, as was true for the child in the lower left. Whereas if you make an early diagnosis in the early days of life, before that's had a chance to happen, and institute treatment, and treatment for the most part is dietary management, avoidance of the offending substance such as phenylalanine, and using special formulas that have everything but that, you can achieve essentially a normal outcome developmentally. So a huge public health triumph. The Tandem mass spectrometry shown at the bottom is the new technology used. We won't say any more about it than that you put a blood spot in one end and you read a spectrogram out the other that tells you not a half a dozen things. Theoretically, it can be many dozens. In practice right now, there's about 24 that are used. It used to be the case that depending on where you were born in the U.S. would determine which things you were screened for, which meant, if you think about it, you could have been born on one side of a state line and been screened, treated, and essentially had a normal life, and on the other side of a state line having devastating neurological impairment because that particular disorder wasn't screened. The panel now is pretty close to being standardized across the U.S., and there's a pretty well-established pipeline now from the state lab to the pediatrician, who's the first responder, ultimately to a specialty clinic, working in partnership, providing a medical home. And now there will be, increasingly is, a need to transition to adult care. If you should be on the receiving end of a call from the state lab and you wonder, what am I supposed to do with this disorder that you probably have never heard of, or if you did, it was a long time ago, I'll sort of draw your attention to these ACT sheets developed by the American College of Medical Genetics, working with the American Academy of Pediatrics. They're available online. And they're basically very practical guides to what's the next thing you do. What do you do? You know, if the call comes now, as they usually do, Friday at 4:30, what do you do for the next 48 hours in order to kind of get things rolling, in order to get the child the kind of care needed while you're mobilizing the specialty resources? Therapeutics are advancing very quickly, in part fueled by genetic knowledge. You probably have heard of the Philadelphia chromosome, which is a translocation between 9 and 22, indicated by the two arrows, called that because that's where it was discovered in the 1960s. And for all these years, It's been used as a marker in chronic myelogenous leukemia. If you have that, first of all, it helps diagnose the leukemia. Secondly, you can use that as a monitor of the success of therapy, because as long as there are cells with it there, it tells you that there's still cancer in the system. Well, it turns out that what's really going on is that the Philadelphia chromosome juxtaposes a gene on chromosome 9, which is an oncogene called ABL, with another gene on chromosome 22 called BCR. It creates a protein that ordinarily does not exist in the cell, but when this translocation occurs, it goes into the cytoplasm and it serves as a driver to cell division, which is fundamentally what gets these cells started as malignancies. Realizing that, it was feasible to synthesize an analog that locks up an ATP binding site. And when that was first used, it's the drug imatinib, or it goes by the trade name Gleevec. For the first time ever, the acute phase patients were experiencing a therapeutic response. That was fundamentally a lethal disorder up until that point in time. It's not quite that simple. The cells actually develop resistance to the drug by mutating around the binding site. But even so, together with other drugs, it now is the mainstay of treatment of CML, and actually several other forms of malignancy, developed on the basis of knowledge of a genetic rearrangement. As you may know, the way individuals respond to medications, the way they absorb, metabolize, and excrete drugs, is to a substantial degree under genetic control. This is a histogram of the thiopurine methyltransferase polymorphism. Individuals, there are not very many of them, to be sure, on the far left end of this curve, do not metabolize effectively. And these are individuals who, with a standard dose of 6-mercaptopurine, for example, or azathioprine, will suffer lethal bone marrow suppression. So knowing who they are, even if it's not very frequent that they occur, can be life-saving to those individuals, because you either use a different drug to treat them or you modulate the dose according to their very distinct metabolism. You may have heard that the drug clopidogrel, which I never pronounce well, but you know it probably better as Plavix, is metabolized by one of the various cytochromes, and that there are individuals with a genetic polymorphism where they're slow metabolizers, and that particular cytochrome is involved in activating the drug. So if they happen to be slow metabolizers, they will fail to activate the drug and hence be underdosed, which means be at risk of blood clots. And just recently, the FDA labeled the drug that clinicians should consider doing genetic testing as a prelude to treatment so as to modulate the dose. If you're in the business of treating non-small cell lung cancer, you know it's not an easy disorder to treat. 10% respond to a kinase inhibitor, gefitinib. The outcome is shown here. Can you predict in advance who is in this responder category? Well, it turns out you can. You can do genetic testing of the epidermal growth factor receptor, not in their peripheral blood, but in the tumor. And if they have a mutation, which is a somatically acquired mutation, part of what drives this to be a cancer, they're the blue line shifted to the left in the dose response curve. These are the individuals who are going to respond. So is it useful? Well, it helps you to figure out, it's unfortunate, it's only 10% who respond, but at least you'll know in advance which category your patient falls in. And if they are not likely to respond, it means this is a drug that's probably not going to help them, and go on and try something else, realizing, of course, there may not be a lot of choices. So the paradigm that is emerging is that we're all born with a certain genetic liability. Occasionally it's overwhelming, like in cystic fibrosis, but mostly it's not. But over time, an accumulation of exposure to environmental agents, one eventually sort of crosses this line from not having a disease to having it. And if we knew what that liability was, could we help avoid that transition, or if it should occur, manage it more effectively? And in this last few years, probably about 3 or 4 years now, since the completion of a detailed mapping of the genome, The flood of recognition of genetic markers associated with common disease has been quite impressive. And the screenshot on the right shows some of the markers associated with asthma. And large data sets now are being tested. In almost any week, the major genetics journals have reports, and there'll be usually reports simultaneously from multiple groups finding much the same thing. And so it's really raised the question, can you predict individuals at risk of common disorders like asthma or diabetes? Well, in fact, the markers that convey risk are usually finding relative risks in the 1.2, 1.4-fold range, which means a 20 to 40% increase of risk, which sounds like a lot, but in terms of absolute risk, it really isn't very much. This has spawned the handful of personal genomics companies, of which I show a screenshot for one. And what you're looking at is the kind of data you actually get. This is not real data. This is hypothetical data they put on the site for a patient named Mendel, which you'll recognize the significance of that choice. The business models are basically the same for these, which is that you go onto a website, create a login, you give them your credit card number. This particular company, it's $400 roughly. The prices vary a little bit from one to another. You then get a few days later in the mail a cup to spit, or a tube really, to spit into, and then you seal it, put it in a mailer they provide, send it back, and about 2 weeks later you get an email that says your genome is ready. And what they've done is genotyped you for about 1 million single nucleotide polymorphisms. And why do I know this so well? Because after having spoken about it, I just decided I'd try it and see what it was like. It's not an endorsement. I have no connection to the company. I won't tell you which one I used, but just to see what happened. So you may wonder, what did I learn from this? First of all, I learned that I can smell asparagus in my urine. That's something I actually knew. There is a genetic polymorphism which determines that ability. Some of you share it and know what I'm talking about, and some of you have no idea what I'm talking about. I otherwise learned that I was at average risk for just about everything else I looked at, for type 2 diabetes, for a whole host of things. I was at slightly higher risk for psoriasis. Neither I nor anybody ever in my family that I've ever heard of has been affected by it. Bottom line to me is it wasn't worth a whole awful lot. Many people view it as so-called recreational genomics. Another term it goes by is cocktail party genetics. And I can vouch for the fact that doing this is worth about maybe 7 minutes of cocktail party conversation, after which you move on. It did not help me in my medical care. It was an experience done mostly because I was curious to see what it was like if I was going to talk about it. This Walgreens thing, we'll see what happens with the FDA, but they were fundamentally planning, as I understand it, the same business, except you'd go to the drugstore instead of the web. But whatever you may think of it, I think if you were to conceptualize our current approach to genetic counseling being one doctor or counselor, one patient at a time, one gene at a time, what these companies are putting forward is the notion of looking at your whole genome. And you could conceptualize them living now at the sort of bottom left of this curve. It's pretty crummy in terms of what it really tells you. It doesn't tell you a whole awful lot. However, if over time the quality of the data behind it improves, and I think there's good reason to believe it will, it very well could turn out to sort of become a mainstream technology. And any of you who have heard of the sort of business term disruptive technology, you can think of mainframe computers that in the 1970s were the sort of sustaining technology of the computer business. Companies that built them, most notably Digital Equipment, the number 2 largest computer company in the world in the late 1970s, asked their customers, are you interested in the personal computer, which was just being developed then? And they scoffed at it. They said, well, personal computers are good to play Space Invaders and things like that. They don't run businesses. So Digital Equipment ignored that trend, only to find, as spreadsheets were developed and other tools, that gradually computers got better and better. So the computer off to the right now does probably more than that room-size thing. As you probably know, digital equipment was bought by Compaq, a PC maker, which in turn was bought by HP. They ignored this trend at their peril. Film as an approach to photography, I know there's bound to be many people that still prefer film as opposed to digital. The initial digital cameras truly were toys. Professionals use digital cameras, I think, more frequently now than they use film cameras, and I think the vast majority of consumers are moving quickly. And if you are really wedded to film, the acid test is not whether you are going to continue to use your film camera for the next few years. It's if somebody handed you $10,000 and said, you have to invest either in a film company or a digital camera company, I think I know which you would choose. Or, remember this in the lower left, the typewriter. You may still have one around, but the chances are low that it's being used much. The first word processors that were pretty clumsy to use, now, if you have a document to produce, the high likelihood is it's coming off a word processor. I guess the metaphor I'm trying to establish is that the personal genomics may not be ready for prime time now, and I have no idea if any of those companies will survive. But I think we would ignore it at our peril and come back in a few years, and it may be a very different scenario. Where is it all going? Many have sort of imagined these kind of gene chips that would diagnose disease, how you metabolize drugs, what your risks are for toxicity. We can now more or less barcode tumors according to patterns of gene expression and distinguish which might respond to particular therapies, and then, as I mentioned, the idea of targeted therapy. And if you're interested in winning $10 million, the opportunity is there if you can develop the first approach to the $1,000 genome. When the human genome was sequenced, we're talking about hundreds of millions of dollars. There were a few papers that came out in just this last few months. You can sequence all the expressed genes now for $5,000 to do that. And if you want to do a whole genome sequence, it's still pretty expensive. It was $300 or $400 million. It's now about $30,000 to $50,000. So there has been an exponential reduction of cost per genome to the point where it's pretty certain within the next 5 years we'll be able to offer genome sequencing for about the cost of an MRI scan. We're seeing advances in therapeutics. Here's actually a screenshot from a paper published by a colleague of mine at UAB. It takes mice that have a model for sickle cell anemia, takes skin cells, corrects the defect in a system where he's transformed those cells from fibroblasts into stem cells using a variety of genetic manipulations. So he takes skin cells, makes them stem cells, corrects the globin defect, and then causes them to differentiate into blood cells and puts the mouse's own now corrected blood cells back into the animal, and fundamentally can cure sickle cell anemia in the mouse. Long way, obviously, from doing it in humans. But these induced pluripotential stem cells have enormous possibilities now in terms of therapeutics. So what I think you're going to find in the next few years is a convergence of information technology and genetics and genomics, which are kind of synonymous because genetics and genomics is the information technology of the organism. And it's coming together towards improved predictive testing, prevention, the ability to stratify disease and predict response with targeted treatments, and then pharmacogenetic and pharmacogenomic manipulations. Now, if you think all the work is done and it's just kind of cleaning up that needs to happen, if you start off with a gene, which is the red bar in the middle, that's about how big it would be next to the entire human genome. So if you stack all the genes like poker chips on top of each other, all you get is that green disk. That's it. So you ask the obvious question, what is all the rest of that stuff doing? And believe me, it is not there as junk is not relics of evolution. Good chunk of it, at least, is active and doing something. And so we have a generation of investigation before us, at least, to try to sort all that out. A few years ago, an effort was made to characterize all the expressed sequences in 30 million base pairs, so that's about 1% of the genome, in which there should have been a few hundred genes. They found that 93% of them were turned on. These included genes that make RNA that makes protein, and some that make RNA that never sees the light of day as protein. Furthermore, they found examples of genes. Here's two that were distant from one another, where a transcript actually started in one and spanned into the other. So there is a lot left to be learned about gene structure and function. I tell medical students that if you want to kind of imagine what the genome is like, the pictures we are accustomed to seeing are a little bit like looking at the Earth from space. Picture a photo you might have seen in the 1960s of a weather satellite in the early days. You could see clouds, you could have seen a volcano, I expect, but you surely wouldn't see what's going on at ground level. If you could miniaturize yourself to the scale of the genome and kind of walk the streets of the genome, it would feel like walking through Times Square on New Year's Eve. That's the level of activity that is happening on a moment-to-moment basis. And that's the stuff that we have yet to really understand. We've also learned that chemical modifications of the genome are significant. And there's a phenomenon of mosaicism, a sobering point. We are all walking around with every genetic disorder ever described in some of our sperm and some of our eggs. All of us carry practically everything. It's just a matter of rare chance that that's the gene that conceives a child, that particular disorder occurs. And we also are all walking around with gene mutations in our cells all the time. We hope it doesn't happen, but for some it will, that one of those will someday become a malignancy. But these are not only causing malignancies, but other medical conditions as well. So there is here, too, a lot to be looked at. Just in closing, I want to put a pitch in for my colleagues. I want you to know that there is a such thing as a medical geneticist. It's a residency that usually is done after 2 years of some other residency like pediatrics, medicine, OBGYN, and others. It is recognized by the American Board of Medical Specialties. There is a board certification system. And there also are genetic counselors who do a 2-year master's training program and are expert in providing education to patients and families about genetic mechanisms. So I want to close with this quote, because the question can be asked. So there's a lot of exciting stuff that's coming, and frankly, since the early days of the Genome Project, people have been talking about it. When is it really going to make a difference? Because the truth is, you may go back to your office on Monday, and you're not going to be ordering genetic tests, probably very many of you. And so, you could come to the conclusion that there's a lot of hype here, and, is it really going to make any difference? So I think this quote, which has come to be called Amara's Law, is helpful here. In fact, in many other areas of life, actually. We tend to overestimate the effect of a technology in the short run and underestimate the effect in the long run. It may not be Monday that everything changes for you, but I'll tell you this. If you could go to sleep today, or maybe you already have, but for those who haven't, if you did, and Rip Van Winkle-like woke up 20 years from now, I would posit that you would not recognize the practice of medicine. And I wouldn't argue that genetics is the only reason, but I would that it will be one of the great engines of progress. And finally, to close, if it requires driving the point home about the exponential pace of technology, let me point out to you that the slide you're looking at now shows the Earth, okay, here and here, and the Moon up here, that was photographed from a satellite currently orbiting Mars. If you just think for a minute in your mind, do the thought experiment of explaining to your 4th grade teacher how that picture was taken. And so that's what's happened in, whatever it is, 40, 50 years or less or more. just imagine now at a point in time where the pace of technological change has become much accelerated compared to that, how quickly some of all this will change. And with that, I will close. Thank you very much. If there are questions, happy to take any.
I'm curious how you see this evolving over the next few years in terms of how any of this will ever be kept abreast of what's pertinent to us.
Yeah, it's an important question, is, how to even stay alert to what all is going on. And, I don't have a single answer to that. The truth is, however much genetics any current practicing physician ever was taught, which was in most cases probably not a whole awful lot, whatever it was is bound to be obsolete as we go forward. There are a lot of interests and efforts in trying to provide educational sort of programs to primary care physicians, mostly through various of the professional societies. Something that I can tell you the American College of Medical Genetics, where I have a role, has been very interested in partnering with other medical specialty societies and using that as a sort of vehicle. Above and beyond that, I think the big question, and it's probably going to be accelerated now in terms of some of the personal genomics, is, as now the FDA has gotten interested in regulation, is there going to be a kind of pathway towards just not only validation of these tests, but also sort of infiltrating the educational systems at every level, from medical school on up through CME.
Well, as a corollary to that, the clopidogrel Plavix warning label that we've read and told about, and said and yet it's so vague. You may want to consider testing for this. Without knowing. But no one's ever told me where, how, who's better not to. So we're kind of sold there's something out there, but very little specifics.
Yeah, so in our institution, actually, when that came out, we actually have been setting up a kind of consult service with the internal medicine groups to help provide that kind of advice. And, there are medical geneticists in the community. I know the people, I guess it's down the road at the university here fairly well. And, there are people that you can talk with in the medical genetics community who would be willing and able to help with that.
Wow, we made it in 3 days. So nothing in particular. Turn in your CME stuff at the desk. Unless Therese has anything, I think we're okay. So thanks again for coming. Give us some feedback. Hopefully to see you next year.